Once again, I hope that you can hear me now. So we make a new start. I say good afternoon, ladies and gentlemen, and most welcome to the reinstated Monivent Webinar Series. My name is Maria Sipos, and I'm the Commercial Product Manager here at Monivent. Together with my colleague, Maria Lindqvist, one of the co-founders of Monivent, we are your hosts today. We are honored to have Professor Tomasz Szczapa and Dr. Michael Wagner as our first speakers. We have 1 hour scheduled, and we intend to take the questions and answers after the presentations, but you are most welcome to post your questions in the chat. So with that said, I would like to introduce our first speaker. Professor Tomasz Szczapa is pediatrician and neonatologist, associate professor at Poznan University of Medical Sciences and head of the second department of neonatology. He is also head of neonatal biophysical monitoring and cardiopulmonary therapies research unit, former officer of education and training of the European Board of Neonatology. Furthermore, he's the teaching officer at European School of Neonatology, member of the European Resuscitation Council, Newborn Life Support, NLS, Science and Education Committee, vice president of the Polish Neonatal Society, NLS, national course director for Poland, and head of Polish Resuscitation Council, Neonatal Resuscitation Working Group. The title of Professor Szczapa's presentation is Neonatal Respiratory Support in the Delivery Room, Current Guidelines and Potential Optimization Strategies. So please, Professor Szczapa, the floor is all yours, and we mute ourselves.
Thank you very much. Thanks for this kind invitation. It is my pleasure. It is my pleasure to talk a little bit on the current guidelines, as Maria said, and potential strategies for optimization. I'm trying to share my screen now. Hope this works. Please, Maria, let me know about that. Okay, so this is a very broad topic, so I decided to highlight the complexity and the most important elements rather than going into too much detail, especially remembering about the limited time that we have. So if there are any specific questions, please ask them using the chat, and hopefully at the end of the presentation we can, or at the end of the session, we can further discuss the elements that would be of particular interest. So we discussed this because some of our patients, they require help with stabilization. Some may require full resuscitation. However, as you can see, in most of the cases, the help that we deliver is focused on the airway management and ventilatory support. What is extremely important is that the current approach to stabilization and resuscitation is based on the knowledge regarding the underlying pathophysiology. We still have many knowledge gaps, but in all areas where it's possible, we try to build our approach based on the evidence from the clinical studies or the animal studies. In the past, it was not always like that. On the left, you can see the approach suggested by Professor Szczapa with his famous Schulze swings. That was his idea for resuscitation. Then, not that long ago, in the 1960s, there was the idea of using hyperbaric oxygen for babies that required resuscitation. It just didn't work because of the pathophysiology. And then in the 60s, what was extremely important is that the physiologists, they came up with help looking and investigating mechanisms between situations that lead to the need for neonatal resuscitation, and they were also testing effects of different modalities of support. And one of their important findings was that it's really important in our group of patients to focus on ventilation, and they also have shown that the idea of using hyperbaric so it was a long road towards the current approach, the current guidelines, which are updated every 5 years. And during that updates, we try to gather all the new evidence, trying to optimize our support. So one of the examples may be the mechanisms of the production of lung fluid and then the reabsorption of lung fluid when the labor starts. We know that it's one of the essential mechanisms that prepare our patients for their first breaths. And if this is unaffected, then as you can see on the movie clip on the right, which hopefully works, this process should be relatively quick. So within seconds, or sometimes a little bit longer, minutes, our patients should be able to establish normal breathing, build their functional residual capacity. But in case there is a problem, then we have to be there and be able to intervene. But one important thing is to know when to intervene, but it's also, I believe, very important to know when not to intervene, or intervene in such a way that we don't do more harm than benefit for the patient. Because one of the important issues regarding physiology, especially in the preterm infants, is actually that most of them, they breathe at birth. So we support them, not necessarily support them. And we also now understand, this is a paper that was published 10 years ago already, how important it is to be least possibly invasive. So in 2015, in the guidelines, what I believe was quite important, there was this point suggesting using different wording, that we should use the term for the resuscitation for the sickest babies that will require full resuscitation, and differentiate that from stabilizing patients or supporting them in transition, which is in most of the cases something that we do, especially for the preterm infant. And this idea was continued in the 2021 update of the guidelines. This is the first part of the resuscitation algorithm. As you can see, opening of the airway, aerating the lungs, they are on the top list here. There is a special box on the left for the preterm infants, which highlight some differences that we should remember about in the group of the most preterm babies. And
Professor Szczapa?
Yeah.
Sorry to disturb. We have apparently slightly bad sound.
Wow.
So
Don't know why.
no, I don't know either.
I can hear you
let's see.
well. I could try to reconnect if you wish.
Now I can hear you loud and clear.
So now it's better.
Yes, it's better. Maybe a bit closer to the microphone. Could be.
I'll move the computer closer to me.
Okay.
Okay. So
thank
first
you.
of all, we need to assess our patient to know what kind of support he needs, and of course, assessment of the heart rate and breathing. These are the essential elements. And while we do that, we can also perform tactile stimulation if we believe that is necessary. And we start airway support according to the guidelines if our patient has not established the adequate regular normal breathing and has a heart rate below 100. And it's very important to remember that ensuring an open airway, aerating the lungs, and ventilation is usually all that is necessary. So in our group of patients, it's quite rare that we have to move forward to chest compressions and the use of drugs. So again, with the guidelines for the initial airway support, we should first place the infant under the radiant heater with the head supported in neutral position. So we don't want the head to be flexed. We don't want the head to be overextended. We want to keep it somewhere in between these extreme positions. What may be helpful, especially in floppy infants, is the performance of the jaw lift, as you can see here on these photos. And if we use two-person method of airway support combined with the mask hold, then it may be associated with more effective ventilation, less leak around the mask, and better control of the position of the head. A lot has changed over the years in the approach to suctioning. Now we only perform suctioning if we confirm airway obstruction. So if we see that the airways are obstructed, only after that we should suction, and that's also the case for the infants delivered through the meconium state amniotic fluid. So we should not go for routine suctioning. In spontaneously breathing preterm infants, we should consider CPAP as the initial method of breathing support, and I will discuss later what can we do to increase the chances potentially. However,
and presentation.
So coming back, I'm not sure which was the last slide that you actually saw. I'm coming back to the initiation of breathing. So we should go for PPV if you have a patient that's apneaing, gasping, or not breathing spontaneously. We should make sure that we have a mask of the correct size, correctly fitted, and with a good seal. And according to the European guidelines, we should start with 5 inflations with the inspiratory time of 2 to 3 seconds. We give 5 of them. The initial pressure and initial FiO2 depends on the maturity of the patient. And after these 5 inflations, we should reassess the patient, looking for the effect. Has the heart rate increased? Was the chest wall movement visible? And depending on that, we either move forward and continue with ventilation breaths, or if there was no effect, perhaps we should try a different airway opening maneuver, or perhaps optimize the way that we are ventilating the patient. If continuation of ventilation is needed, then according to the European guidelines, we go for ventilation with a rate of around 30 per minute, optimizing the pressures as needed, monitoring the SpO2 and heart rate, and remembering also about the titration of the oxygen concentration depending on the oxygen saturation. If there is no increase in heart rate or chest movement, these are some of the elements that we should consider. Perhaps it's the problem with the equipment. Maybe something is disconnected. Perhaps it's about the head position. Perhaps it's about the mask size or the way we seal the mask. We should remember about other potential airway opening maneuvers. We should also remember about the potential need for gradual increase in the pressures, in inspiratory pressures that we are using. If we have a respiratory function monitor that Michael will cover in his presentation, we should check tidal volumes and the leak on the monitor. It may be helpful to optimize our ventilation, and then we should repeat those inflations and reassess and continue the monitoring of this patient. There are different mask holds, for example. Sometimes the way that we hold the mask, how we seal it on our patient may have an impact on the efficacy. In some situations, it may turn out that the face mask is not sufficient, and then there are alternatives. We can go for either tracheal intubation, or if possible, and if it's available, we should consider using a laryngeal mask. For now, due to the available sizes, that's limited to infants at or above 34 weeks of gestation, so it may be difficult to use those laryngeal masks in smaller infants, hence the recommendation. There is increasing evidence that it may be a very effective tool to secure the airways if the face mask ventilation was not effective, and it may be easier to achieve that than to intubate the patients in case there were problems with intubation. Back in the day, the guidelines suggested using oropharyngeal airways. Now we don't routinely recommend that, especially not in the preterm infants, because there is now evidence that especially in those babies below 32 weeks of gestation, the use of oropharyngeal airways instead of optimizing the airway patency may have an opposite effect. When we talk about assisted ventilation devices, I assume that most centers in Europe routinely use TPs resuscitators. However, at least in our part of Europe, there are still centers that would routinely use the self-inflating bag. And now we know that there are several benefits of using TPs devices instead of self-inflating bags. One important benefit is that we can easily deliver end expiratory pressure at the value of 5 or 6 centimeters of water. It's good to have a self-inflating bag as a backup, but if it's possible, we should go for the devices like TPs in the first line due to the benefits, because we also now know that it may have important clinical implications, such as lower risk of complications such as bronchopulmonary dysplasia due to better control of the pressures and volumes that we are delivering during the delivery room stabilization. So how can we optimize our management? First of all, by understanding physiology. There are several, for example, reflexes that we can trigger, for example, while we are placing face masks. If we use pressure which is too high, then sometimes we may have a better seal, but we may cause the TCR reflex or diving reflex, which may cause apnea, bradycardia, and closing of the glottis. And then our non-invasive ventilation using the face mask or other interface will not be effective. The way how the gas is optimized may have importance. I mean, the temperature, first of all, the pressure of the gas, procedures such as suctioning, instead of helping, if we want to use them, if they are not absolutely necessary, they could also result, for example, in desaturations. If we forget keeping the correct temperature of the patient, that can also result in apnea. And if apnea occurs and if the glottis is closed, then we know that the air, instead of going into the lungs, will go into the stomach. So it's really important that for the non-invasive respiratory support to be effective, that we have a spontaneously breathing patient. So here you can see some of the effects. So if we press too hard, it may have an opposite effect, be related with the closure of the glottis and then ineffective ventilation. So it may be really important how we stimulate our patient at birth. And interestingly, there is limited information, limited knowledge regarding this. We know that tactile stimulation may play a role, the amount of oxygen that we use in the preterm infants, some drugs that may be used, such as caffeine, how we optimize end expiratory pressure. All these parameters may have effect on breathing. Here's one of the examples from the animal studies showing that also the fraction of inspired oxygen that's used for resuscitation may also play a role in the preterm infants. And also the type of stimulation. So here is a very interesting study by Janeke Decker, Ariane Tepas, and the group that have shown that if repetitive stimulation is using instead of the standard approach, this may have beneficial effects on the oxygenation. And this is something that is going to be tested in a multi-center study. I also mentioned the importance of heating and humidifying the gas. This may have an effect on breathing, but what we know for now already that it for sure affects the temperature of the baby on admission to the an ICU. Something that I mentioned regarding the devices that we use for ventilation. Here you can see the difference between the TP's device and self-inflating bag. So we can see that we have more control over the pressure. We can deliver the consistent and expiratory pressure. With the standard self-inflating bag, it will be much more difficult, and there will be more variation in the pressures and in the tidal volumes that we are delivering. And as I mentioned, there is already evidence that can result also in less complications such as BPD. For sure, the use of an expiratory pressure is very important, something that can be easily optimized using this knob here, this white knob on the TP's device. That influences how the lungs are aerated. There are routinely, we are used to one, let's say, value of the pressure around 5 or 6 centimeters of water. But animal models have shown that perhaps we should change the strategies, that maybe higher and expiratory pressures or variable pressures may be of benefit. So gradually increasing the pressures depending on the response of the patient, and then also decreasing these values if needed, because what was also found that if these pressures are too high, then it may have good effect on the lung expansion, but it may affect the pulmonary blood flow in a negative way. And this idea of dynamic approach to the end expiratory pressure is also tested in the multi-center trial, which is called Polar trial. So we're really looking forward to the results. Talking about the devices and interfaces, I will just briefly mention that it may play a role what kind of interface we're using, especially in the most immature babies, so for the smallest sizes. So for example, the RAM cannula in its smallest sizes, it's really nice to use. Personnel likes it, but as you can see, the resistance that was recorded using this interface was much higher as compared to the other interfaces, and that can have an effect on the final result of our attempts to stabilize the patient using non-invasive methods. It's also true not only for the interface, but also for the devices that we're using. So here, for example, you can see a comparison of the imposed work of breathing depending on the device that's being used. Just compare the infant flow system and the Neonatal system. There are big differences regarding the pressure. This is something that we know from the studies that were carried out in the NICU, that indeed the work of breathing that was recorded in patients with the variable flow CPAP was lower as compared to the standard CPAP. Here is an example of a new interface that can be used in the delivery room. That's the variable flow system using the Coanda effect, which results in less work of breathing. If you, I hope that you will be able to see the screens. This is the test, simple test lung. You can see how with the standard module, the pressure transfers to the machine, which gives us the idea of the effort also for the patient to breathe using the standard tubing. And please observe the manometer here with the AirPAP system. And in the mid part, you can see the actual measurements that were performed in the in vitro study that showed significant differences in the imposed work of breathing between the standard system and this variable flow system. Here are the PV loops for these two devices, and we actually tested, or was the study by our Swedish colleagues, but my center was invited, and we had the pleasure to join the study. It was the study assessing the impact of using such variable flow system with nasal cannula against the standard system, standard TPs with face mask. So here you can see the difference, and I will briefly go to the results. It was shown that with the new system, there was less need for intubation. So this is the summary of the findings. The additional analysis also have shown that there was less need for PPV in the group that was stabilized with the AirPAP system, and there was less need for mechanical ventilation, not only in the DR but also during the first week of life. And we believe that it had to do with the work of breathing, but also perhaps due to less problems with apnea caused by the stabilization of the face mask. So several mechanisms could have played a role. When we talk about optimization of the ventilation, respiratory functions monitor, they can be really helpful. I think Michael will talk more on that. Similarly, end-tidal CO2, perhaps newer methods of enhanced monitoring, such as NIRS. Gerhard Pichler has shown that when we use NIRS in the delivery room, patients spend more time in the range. They spend less time in hypoxia. It was tested in a multi-center study. There was a difference between the group that had the NIRS, additional NIRS measurement was 4% different, however, not statistically significant. The problem here was that in the end, the study was underpowered, but definitely that's an interesting idea that requires further investigation. And then finally, when we talk about oxygen supplementation, I just wanted to briefly mention that it's really difficult to keep our SpO2 targets. There is really a relatively small proportion when we are really able to keep the patient in the target range. And perhaps talking about newer technologies, perhaps there is a room for automated control. Many NICUs are already using automated FiO2 control in the mechanically ventilated patients. This is a study on animal model that has shown that it's feasible to use the automated control of FiO2 during resuscitation, and that it allows the patients to spend less time above the target range for the SpO2. And a study published last year, the first one actually performed in the preterm infants with very similar results. So in summary, in most situations requiring neonatal resuscitations, the basic management focusing on airway management, lung aeration, and ventilation will be effective and sufficient. We know that we often have to use positive pressure ventilation. However, it may be ineffective, especially in non-spontaneously breathing patients. It seems that the need for the positive pressure ventilation could be reduced when we better stimulate spontaneous breathing, perhaps use different interfaces. We have perhaps also optimize our CPAP strategy, which is currently assessed in a trial. And for sure, we have to continue our search for new methods for optimizing respiratory care, remembering about the pathophysiology of postnatal adaptation. And the citation, the quote from Colm O'Donnell that I really like, that it will be a continuous process that we have to obtain or to optimize what we do. I'm taking the opportunity. I would like to invite you to Rome and to Poznan. Thank you very much, and sorry for the technical problems.
Thank you, Professor Szczapa. Let's see, can you hear me again? Yep. Good, perfect. Thank you for the presentation, very interesting. I know that we already have some questions, but we keep them for later. So then our second speaker is Dr. Michael Wagner, consultant neonatologist from the Medical University of Vienna in Austria. Dr. Wagner is the director of the Pediatric Simulation Center at the Medical University of Vienna. His research is primarily focused on simulation-based medical education, the translation from training to clinical education, and on improving patient safety for pediatric and neonatal patients, but also increasing healthcare provider safety. The title of Wagner's presentation is Respiratory Function Monitoring Application for Training and Clinical Supervision. So please, Dr. Wagner, the floor is yours.
Thank you very much for the introduction. I'm trying to share my screen. Can you see anything? Okay, seems like I need to log in again. Very sorry. Just give me a second. Okay, let's try again. Okay, do you see my slides?
Not yet.
Interesting. It worked yesterday. Okay, I'll change my browser as well. Okay.
Perfect.
So do you see my slides now?
Yes.
Okay, great. Yeah, thanks for the introduction. So I'm very happy. Tomasz already gave us a good overview about neonatal resuscitation and airway management. So my talk will be more focused on our experiences when using respiratory function monitor, our research, some published research, some research that is still ongoing and unpublished. And yeah, I would like to start with the beginning again. So we heard a lot about neonatal resuscitation, and it all begins with the birth. And we know from literature that about 5 to 10% of newborn infants need some kind of respiratory support. So that's quite a lot. And we heard from Tomasz about the European resuscitation guidelines from 2021 and how to assess the baby and how to give inflations after birth if the baby's apneic, if the heart rate is low. So I don't want to go into too much detail on that. So when we teach our young fellows, usually it seems like mask ventilation is easy, but actually when we look into it in more detail and if we measure what healthcare professionals are doing when doing mask ventilation, it's still a very difficult technique. So we see that mask leak is a very common problem and it's often unrecognized. And if it's unrecognized, you often have insufficient tidal volumes for the baby, heart rate stays low, and possibly you're going into a situation where you need to do a full resuscitation with chest compressions just because the airway management is not good enough. So it's clear that we need to put a lot of focus of what we are doing on airway management. So previous literature also demonstrated us that mask leak is very high. It's up to 70%, even in experienced healthcare professionals, but it's usually more in healthcare professionals that are younger, who have less experience. But still, we see also in neonatal consultants that they still have quite a high mask leak, and it also makes a difference if, for example, if there's an enteral feeding tube still in place, if you do a one-hand technique or a two-hand technique. So yeah, the good thing is we can measure it. This is something that's not routinely done in clinical care, but we have devices out there which can effectively measure our inflations. So we have some research devices, and we now also have the Neo 100 that is clinically certified. So that's also the reason why we were able to use it for a clinical study, which I will talk to you a little bit later. A respiratory function monitor can also help us to identify problems, to identify difficult ventilation. So if we have a very high mask leak or if we have an airway obstruction, the respiratory function monitor can possibly guide us to improve our ventilation technique. So Tomasz already talked about Mr. Sopa and how to improve airway techniques. So there's a recent meta-analysis about respiratory function monitoring to improve outcomes in neonatal resuscitation. So this meta-analysis included 443 preterm patients, and they couldn't find any significant difference for in-hospital mortality when using a respiratory function monitor hidden or visible. However, what they found, but this is only secondary outcomes, so the analysis was not powered for that outcome, was that there was a reduction of IVH and PVL, and there was also a reduction of very high tidal volumes, so tidal volumes above 8 milliliters per kilogram. We don't know if there's an association, but it's definitely something we need to look into closer. So there were 3 randomized controlled trials included. And if you look at these trials in more detail, you will see that all the trials used different respiratory function monitors. One of the biggest studies that was included in that meta-analysis was the so-called MONITOR trial, a multi-center randomized controlled trial of respiratory function monitoring during stabilization of very preterm infants at birth. They included 288 preterm patients from 24 to 27 weeks of gestational age. And the monitor was either visible or not visible. The patients were randomized. And the authors couldn't find a significant difference in the target range for expired tidal volume. So the target range was 4 to 8 milliliters per kilogram. Interestingly, they found also, that's why they found it in the meta-analysis, because this was the largest cohort that was included, a significant reduction of IVH and PVL when the monitor was visible. But again, no significant difference in the primary outcome, the target range, for between 4 to 8 milliliters per kilogram. So one of the problems that come up here is that the monitor that was used is the research monitor. So you see it here on the upper right side. And the monitor is great. So you get a lot of data. You get the curves, you get different values from PEEP to PEEP, flow, saturation, heart rate, oxygen, and so on. So you have a lot of information. But the authors of the monitor trial published a secondary analysis of a questionnaire that the resuscitators, so the providers using the RFM, received. And what they are writing in the publication is that nearly 50% of all the providers had insufficient training, and nearly 80% felt that more training would be helpful for interpreting the RFM data. So when we are integrating new technology in the delivery room, in the NICU, or anywhere in healthcare, we should talk more about human factors, and we should integrate human factors perspectives, because if you're just integrating or putting a new technology or monitor into a setting where it's uncommon or where people don't know how to use it, it will not be very helpful usually. And I do a lot of simulation trainings and also research in the field, and we know that this is a very, very important perspective we should put into account. So what are the human factors for those who haven't heard him? It's about, for example, personal stress. So you don't have a good day, you're unconcentrated, you are distracted by something, your teamwork, your communication in the team is not very good. So these are all things that influence how humans interact with technology. And usually that's something that we don't study a lot. So usually it's just taking a new device, putting it in the NICU in the delivery room, and people should just use it. So in my opinion, it's very important to integrate the human factors perspective. So to think about what equipment is used, what about the usability and feasibility of the monitor? Is it easy to use or is it difficult to understand? For example, if you have that research monitor that is great in recording different curves and numbers. It might not be very good if you're in a stressful situation. So you have an asphyxiated newborn or an asphyxiated preterm baby. It's difficult to do mask ventilation and you're close to resuscitation. Then you have a new device and you need to interact with that device. And if you're not trained well enough, or if you haven't tried this for a lot of times before, then it's getting quite difficult to have that complex data to integrate it and to adapt what you're doing according to the technology. It's also about how much, as I said before, how much training you get and how often you repeat the training. It's also about how to teach to use the training. Other things that need to be discussed are the best monitor position. So, in the delivery room or the NICU, we have a lot of monitors already, and adding a new monitor might make some problems. So this is something that we need to evaluate. What's the best position so that everybody in the team can see it, or is it necessary that everybody in the team sees the monitor? And what takes attention in the delivery room, or maybe the new monitor could also be distracting. And of course, also who is involved in the intervention when the new technology is used. Is there an additional supervisor or so-called coach? What about the other team members? How are they interacting with technology? So this is something that needs to be considered when doing research with new devices. So my previous research was a lot focused on attention, especially when integrating new technology, also distraction and outcome parameters. So for that, we use eye tracking glasses. And this is, for those who haven't seen them before, this is how we set them up. So we put on eye tracking glasses in a simulation setting or in a clinical setting to somebody, to the provider, and we see his or her visual attention. We see what they're focusing on. We see what distracts them. And we can also qualitatively, but also quantitatively analyze their focus and, of course, also their distraction to learn more about their human technology interaction. So here, for example, you see a heat map after analysis to see what the focus of that provider was. Okay, let's talk a little bit more about respiratory function monitoring use in training. So we wanted to find out how feedback devices are influencing the visual attention of providers and also the outcome of providers. So what we did here is we performed a randomized crossover simulation study, and all the participants had to perform chest compressions and ventilations, and either started with a visible or with a hidden monitor, and then switched to the other group. And while doing so, they had eye tracking glasses on. So we included 40 healthcare providers, and it was interesting to see that the outcomes were significantly better when using feedback device. So the total chest compression score was better, and the mask leak was lower when a feedback device was used. What we also identified is that feedback devices are consuming visual attention. So in our study, the feedback devices had about close to 50% of visual attention during the scenario. And it's also interesting to see that while the primary area of interest without a feedback device is the infant chest in such a situation, like chest compressions or ventilations, it shifts from infant chest to feedback device, and it's only about 30% afterwards. So we wanted to find out if visual attention is also influencing outcomes. So we did a secondary analysis, and we only used the masked monitor group. And what we identified here is that visual attention has an influence on ventilation quality. So we know that from other studies from adults and especially anesthesiologists, but we were able to confirm this also for airway management. And we identified that frequent gaze shifts, so from infant chest to the monitor, to the nurse, to the monitor, to like the vital parameters monitor, to the nurse, then to the infant again, this is increasing mask leak. And if you have a focused visual attention on the thorax of the patient without doing all these gaze shifts, and again, this is the group without feedback devices, this was associated with less leak. So if you're focused with your visual attention on the patient, then your mask leak is reduced. That was measured with a respiratory function monitor. So the authors from the monitor trial, they also used eye tracking glasses in 14 neonatal resuscitations in a clinical setting, and they had quite similar results. So 30% of the time, the providers were looking at the monitor. So we identified that feedback devices are helping to improve outcomes, but still it's unclear what's the best integration. So for training and as well for clinical education. So what's the best integration when having feedback devices? And for that, we did a randomized controlled simulation study with 167 participants without any prior experience in neonatal airway management. The scenario we chose was an elective intubation and ventilations for 60 seconds before intubation and after intubation and between intubation attempts with a maximum of 5 intubation attempts. So this was the study design. I will go into more details in the next slide. And the primary outcome for ventilation was the percentage of expiratory tidal volumes within the target range 4 to 8 milliliters per kilogram. So we chose the same primary outcome as the monitor trial. And for intubation, it was the number of intubation attempts. So in the next slide, my colleague and future PhD student and first author of this study, Robin Tworski, will tell you more about the study design.
Michael, there's no sound from the video.
Excuse me?
There is no sound on the video.
Okay, I'm very sorry.
Yeah.
I was able to hear the sound, but then I will guide you with my own voice through the video. So this was the group A, the no access group. So this was basically the control group. This is what we do in a clinical setting usually. So we have someone doing the mask ventilation and doing the intubation, and we just recorded it. But the supervisor, so we had a trainee and the supervisor was just giving feedback subjectively. So for example, if there was a thorax movement, or we also had a patient monitor, so if the heart rate was increasing, for example. So the second group here, the supervised access group, we had only the supervisor was able to see the feedback of the monitors, and the trainee was able to focus completely on the patient. So we did that because we thought that the monitors might distract the trainee, and we wanted the trainee to have full focus on the patient. And so just the supervisor had access, got this objective feedback, and was able to tell the trainee. But of course, this could also potentially give some delay because the supervisor needs to integrate the data and then tell the other person. And the third group, the full access group, was the group where both the trainee and the supervisor had access to the respiratory function monitor as well as to the video laryngoscope. So here's the data. So the control group had the worst performance, both for the target range for tidal volume as well as the number of intubation. And the group B, so where only the supervisor had access to the monitors, visual access to the monitors, this group had significantly better results for both intubation attempts as well as target range for tidal volume than group A, so the control group. But the best performance was in group C, so where both had visual access. And this could be potentially due to less delay when integrating data and tell the other person. And also, of course, during communication, some misunderstandings can happen. So we were able to show that the best setting for training, for simulation training, but potentially also for clinical supervision and education is if both have visual access to the monitors. The providers also were wearing eye tracking glasses. So this is just an example of what it looks like when we are analyzing the data to see the visual focus of the providers. And we're still analyzing the data, but just to give you some preliminary data, we were able to show that in group A, so the control group, and B, where only the supervisor had visual access to the monitors, the visual attention, the most area of interest was the infant's chest. And in the third group, when the monitor was available for both, so the trainee and the supervisor, it shifted again from the infant's chest to the respiratory function monitor, but still with improved outcomes. And we also assessed the workload with the NASA task load index. And in the group where both had visual access to the monitors, the workload was the less. Okay, let's go on to RFM use in a clinical setting. So I showed you the data of the meta-analysis, and especially from the monitor trial. And that was a bit frustrating because when we used respiratory function monitoring in training, we saw the big impact of better results. So we thought, okay, what could be the problem? Why are we not seeing any better results when having this technology that is helping us to guide airway management? So we wanted to assess ventilation quality with visible and mask monitor in the delivery room and during neonatal intubation procedures. But we changed 3 key elements. So the monitor's design, supervision, and the training effect. So for monitor design, we know from previous literature that usability is a key issue for lessen errors when using this technology or the monitors and to promote a safe use. So I told you about the monitors that were used so far in the trials that were integrated in the meta-analysis. These are usually research monitors. They're very great in capturing data, but they might not be the best for clinical use. So when the new 100 was on the market and certified for clinical use, we tested it and we saw that this is really nice for training, but also for clinical use, and it's easy to understand. You usually don't need a lot of training to interpret the data. You have this graphics which show you if you're in the target range that we're aiming for, and to see instantly what's your mask leak, what's your positive inspiratory pressure. So we said, okay, let's try this monitor because it might be a more easy to use monitor, and in terms of making it easy for healthcare professionals and human factors, we thought this might make an impact. So the second thing is the supervision. So Adam Chang and Betsy Hunt, 2 pioneers in cardiopulmonary resuscitation, they demonstrated some years ago already how much impact the CPR coach, so a person that is coordinating and assessing what's going on during chest compressions and CPR, that such a person is very helpful, and that is improving overall CPR and patient outcomes. So we thought, okay, let's try to have someone that was similar to the other study, the simulation study that we did with the supervisor. We thought it might be good to have a RFM coach or someone who is supervising you and is giving you instructions. So we tried to have that in most of the inclusions. We didn't manage to have it in all of them, but in most of them we tried to have someone who is helping with integrating the data, understanding the data, and then adapting the ventilation strategy accordingly. For example, in the visible group, when I was supervisor for one of the fellows, I saw that they had a high mask leak and the tidal volume was not good, and also the thorax was not moving, the heart rate was low. So I saw that on the respiratory function monitor, but the trainee just didn't see it because she was very focused on just the patient without looking at the monitor. So I said, hey, let's look at the monitors. Your mask leak is very high, your tidal volume is not good, the heart rate is low. So let's try to adapt this and that. And that was really helpful and beneficial, I think. And for me, it was good because I saw what the problem is and what can be improved. And the last thing is the training effect. So we did a study in 2019 where we included 650 participants for chest compression feedback. We had 2 groups. We had a baby group and an adolescent mannequin, and we randomized into 3 study groups. So the first one was an instructor feedback group. So this is just regular CPR training that most of us are doing. So we have an instructor who is telling the student, you should do deeper compressions, you should do the compressions much quicker. So the second group was a self-learning group. So we only had the feedback device available, but no instructor. And the third group was the device that was available for the instructor, who had objective feedback and was able to give that objective feedback to the student or to the participant. So we did this training in the randomized groups, and we did 1 hour later an assessment with all the participants, where they had to do 2 minutes of chest compressions without any feedback, just to see if there's a training effect depending on the study group. So what you see here is this is for the training. The first 2 graphs are for the training, the other 2 are for the assessment. And both groups, so the self-learning group, but also the group where the instructor and the device were available, had significantly better results for the total compression score. And interestingly, this was also true for the assessment, where they did not have any instructor or any feedback devices. They just did the chest compressions, but they were able, those 2 groups that had a feedback in the training also had better results later on in the assessment. So we think that when you do a randomized controlled trial and you're randomizing the patients, you have the problem that providers will have settings where one time the RFM is masked, the other time it's visible, then it's masked again, it's visible. And every time the RFM is visible, you're kind of learning how to improve your mask ventilation. And this is also something that we've seen in a clinical setting. So at the beginning, when providers are first doing mask ventilations, they have usually high mask leaks. They have low tidal volumes or very high tidal volumes, for example. And they're getting better and better every time they use the monitor. So this is why we decided to not do a randomized trial, but to rather do a control and intervention setting. So we included all gestational ages, the delivery room and intubation, so the mask ventilation before intubation and also the ventilation on the tube. We decided to change 3 key elements to have an easy-to-use monitor, an RFM coach if available, and the non-randomized setting to reduce the training effect. And the primary outcome was the proportion of ventilations within the target range. The data collection was with the RFM. We also had a questionnaire for the supervisor or study nurse. And we also recorded patient data like gestational age and weight. So this is how we used it in a clinical setting. Some of the participants also were wearing eye tracking glasses. So here the provider is looking at the RFM and on the infant chest. And this is how it looks like in a clinical setting in the visible intervention group. So, as I said, we included 90 patients from 400 grams to 5.5 kilograms. And we had intubations, we had delivery room inclusions, and also bag mask as well as T-piece inclusions. So this is still unpublished data, but what I can show you so far is that for the primary outcome, the tidal volume target range 4 to 8 milliliters per kilogram, the visible group showed significantly better results. And this was also true for reduction of mask leak and especially reduction of very high tidal volumes above 8 milliliters per kilogram. And one thing that we also saw during our study is when, so we had a small number of patients also included with laryngeal supraglottic airways. And this is what it looked like in the mask group. So we had the respiratory function monitor, which was hidden. So also the LED was hidden. And we had laryngeal mask insertions where the providers were able to see the RFM. And we saw that the RFM is really helpful in guiding supraglottic airway positioning. So we still need to analyze the data here as well, but what we identified is that the providers needed much less time to insert the laryngeal mask and to see if it's well positioned when the RFM was visible, because you see a lower mask leak and you see if you get some expired tidal volume. And this was also confirmed by fiber optic endoscopy here on the right side. So we are super excited to see that data and to have future trials. So we are at the moment also planning a multi-center trial and using the RFM in a clinical setting. And if you're interested in that, just let me know. So what are the key questions for future research? So we need to think more about the optimal monitor design and how to interact as human beings with technology. Do we need different monitors? Do we need an easy to understand monitor for those who are not very well trained with the monitor, or maybe an advanced version for those who are very well trained with the monitors? We need to think about usability and feasibility, and what makes a monitor a distraction, or at what point a monitor makes a distraction. We need to think about monitor positioning in the room, and also, of course, about the optimal application for teaching and clinical supervision. So should the monitor be visible to both or to only one person? What about the communication when using technology? Should we add acoustic feedback? And of course, in the end, also to analyze the influence on patient safety and patient outcomes. So this all would not be possible without a great team. So I'm very thankful for our team. So we have different subgroups. So here I'm very thankful for the airway research team. And yeah, to summarize, we were able to see in the simulated and clinical setting positive effects on ventilation quality, but we still need more data to see really the effect on patient outcome, especially with the meta-analysis available. We need to think more about human factors and human technology interaction, about the best integration in a stressful clinical environment. So I would like to close here. I'm very looking forward to your questions. Here you see my email address, you see the Twitter, LinkedIn from our research group, and also my personal one. And if you're interested in a research collaboration, or in if you have any questions, just let me know. Let me know. Thank you.
Thank you so much. Let's see if we can. Yep, thank you both, Professor Szczapa and Dr. Wagner, for your presentations. Let's see if I can start my video. If not, then yeah. We have a couple of questions from the audience, and the first one is for Professor Szczapa, and it is: do you think we will see more RFMs in the delivery room in the future?
Yes, the short answer would be yes. I think so. However, we need to be sure that we know what we're doing, and I think what Michael said about the right training, also for right preparation for the use of RFM, is very important. So that people don't have the wrong impression that it doesn't work, because it may not be due to the device, but due to how to use it. So I would expect that, and I think this would be very helpful. Similarly to the approach to mechanical ventilation, also many years ago, it was not a standard to monitor respiratory function. Now, a neonatologist would not imagine a ventilator without a part which is providing information about tidal volumes and other parameters. So yes, I believe so. But as Michael said, more research is needed, and perhaps also a standardized way of the application of RFM, and also a standardized way of teaching how to use that. So I would expect that in the future will be a part of the newborn life support training. But as with other methods, we need more evidence to be able to recommend that.
Okay, I think that was also one of the other questions, if you were talking about the guidelines. The question was, the guidelines state that the respiratory function monitor should be used if available.
Exactly. So it's not like with pulse oximeter that you really have to have it in the DR. It's more, let's say, it's a softer, let's say, recommendation. So if you have it and you know how to use it, use it. But for now, it's not as with the current knowledge, it's not as essential as a pulse oximeter or ECG monitor, for example.
Okay. So let's see. The other question was for Dr. Wagner. Maria, if you can see more, then let me know. I know that I've noted. Do you have any advice based on your experience on how to successfully implement new equipment, or more specifically the RFM, into clinical practice?
Yeah, that's a good question. It's a difficult one. So, as Tomasz also said, I think it will be different for every team. So team structures are different, experiences are different. So there's not like one size fits all solution. I think what needs to be done, especially when having new technology, you need to do trainings. You need to have people understand what they are doing, what they are seeing. And we shouldn't lose the focus on the patient. So I think it would be wrong to say, hey, we have a video laryngoscope, we have a respiratory function monitor, so you don't need to look at the patient at all. Just focus on the technology, and you will be safe. I think this would be the wrong direction. I think that the patients should always be in the focus. But when we're using new technology, and we know that technology can be helpful, and we will see much more of it in the future, then it would be good to have someone who really understands how to use it and to teach others on how to use it. So if you have any simulation mannequin, go with it to the delivery room or to the NICU and do insight to quick and short trainings. So you can do them before you're doing rounds or afterwards. Doesn't need to be very long, but just have a mannequin, let the providers do the training, and let them try how to do mask ventilation, what they see on the monitor, and do that like over and over again. So we know from simulation literature that this knowledge will be gone after 3, 4, 5, 6 months. So you should do regular retrainings, and you shouldn't. You just do them. If you ask people, "Oh, do you need a training?" They will tell you, "No, I don't need a training. I know how it works." But you should just offer regular trainings for everyone. And I think it's always the easiest way to just take the equipment, go to the providers, and let them do the training. I'm not sure if that's answering your question, but as I said, I think there's no one size fits all training. Everybody needs to think about their own team structure, but that it's definitely necessary that you should do training. It's the same with video laryngoscopy. It's not only respiratory function monitor. It doesn't help to just give the device there and don't tell the people what they see or how the technique is differently when using a new technology. They need to do training in simulation mannequins. You need someone also there when they are performing mask ventilation with an RFM on the patient. So I think also that only simulation training is not enough. You should have both, like the supervision and training in a simulation setting, but also the clinical supervision from someone that knows the device very well and can also troubleshoot if something happens.
Okay, thank you. We had one more question, and that was, what are your thoughts about the link between IVH and high tidal volumes? I think it was. And that is for both of you.
Yeah, well, that would be another point justifying the use of RFM. I mentioned the example of the assisted ventilation devices. So for many years we had the feeling that you have more control over the ventilation when you're using TPs instead of self-inflating bag. But now we have more evidence showing that actually we will have less BPD, and it just makes sense. And so with the IVH, yeah, theoretically, absolutely, there could be the link. So whatever, it's not only the brain but the lungs as well. So if we can be more precise and adapt better for the needs of our patient, thanks to the tools such as RFM, yeah, I believe we should use it. So that would be just another argument that could be used for the use of RFM.
I think it's important to mention that we don't know at the moment if there's a direct link between very high tidal volumes and IVH. There could be an association, and it looks like there is some, and it could be due to different, the lung is inflated like very, very much, and then you have different flows to the heart, to the brain. And it's the same like with blood pressure. If you have very different blood pressures in the patients. So this is basically the same concept as with physiology-based cord clamping. We try to keep a stable blood pressure and flow for the baby, and try not to cut the cord to have a very different blood pressure. So I think we don't know at the moment. There's no clear evidence, but it seems like there is a link, and we need to study it in more detail.
And let's see. I can't hear you, Maria, but maybe everyone else can.
Oh, I was muted. Okay. Now we have one more question in the chat for Professor Szczapa. So you talked about different ways of optimizing respiratory management, and just which one do you think might have the largest impact on clinical outcomes are the ones that you mentioned?
Very difficult or impossible to answer. It's just, multifactorial. So one could only speculate. So we should try to optimize all of them, but it can be very dependent on the patient. So it's difficult or impossible to answer that in a direct way, I'm afraid.
Yes, of course. You talked about, we need more research in order to be able to recommend or have a stronger recommendation on RFM use in the guidelines. But do you have any idea of what level that evidence has to be on? Like what needs to be proven in order to make a stronger recommendation?
Well, there are different basis for different recommendations. So there are some areas we have very strong evidence from different RCTs, but there are also some recommendations which are based on expert opinions. So we make some speculations based on what we know from animal studies or physiology. So again, there is no set level, but but we always in different types of recommendations we always show the evidence. So in the latest edition of the guidelines, the ERC guidelines, I believe it was quite well put that in the first part you have the practical clinical part. So for people who want to look for brief clinically useful information, but then if they want to learn why was this kind of recommendation done, they go to the evidence section, and then the evidence is summarized, plus they can check the references. I believe in the last edition we had like 300 references, something like that. So there is no let's say like basic threshold, and there is always a group of people discussing it. It was a really long process with the ERC update, many meetings, so different people working on different parts of the guidelines, and many different discussions, some of which were not very easy. But maybe that's the beauty of it, that it's you don't have only right and wrong answers. We try to be closer to our goal, but there are many knowledge gaps, and in many areas it's largely based on expert opinion or data from animal studies.
Great, thank you. you have any more questions, Maria?
No, I think I've scribbled down those that I could see in the chat, and I think we have covered them. We are, we have had the webinar session for 1 hour and 20 minutes now, so we will round up, if that's the right word to say. And we thank you both for your presentation and for taking the time. And we thank all the participants. The video recording will be available in a few days, and we will get it fixed. So you should have the full presentation. So with that, I say thank you. And Maria.
Thank you very much.
For you.
Thank you very much.
Thank you.
Thank you both.
Thank you. Bye-bye.
Bye-bye.